Well, good afternoon, everybody. Thank you so much for coming here in the afternoon, especially for those of you who are putting up with me again, because I have talked about this topic before. This is actually the fourth year in a row that I've talked about the management of adverse effects related to aromatase inhibitors. So clearly, I do think this is really an important topic, one that deserves some spotlight every single year, and we're all lucky that I actually have new things to talk about every single year when it comes to this topic. The reason I used to say I really wanted to put a spotlight on it is because, as you know, there are a lot of other cancer conferences in the country, and most of them, not this one is a really good example, but most of them focusing on treatments, the best new treatments, chemotherapy agents, how to treat breast cancer most effectively. Usually, the conferences are not having a spotlight on how to manage any of these adverse effects that these new treatments, exciting treatments, are causing. So I've always wanted to, when I speak, even though I am a college professor and actually my main job is to give lectures to my pharmacy students at the Albany College of Pharmacy on every single chemotherapy agent and provide them with the information so they can take their boards and know about the adverse effects. But when I get a chance to speak anywhere, I love to be invited places because I want to talk about something that doesn't get as much press and highlights the actual studies that are looking at just treating the adverse effects. So even when I say that, though, some of the news this year is about that some of the data is not getting swept under the rug anymore. Because look at this headline. This is actually an editorial in the country's top oncology journal, calling attention to what I've been saying for the last 4 years. So I think everybody is starting to recognize this, that we want to talk about not just how great aromatase inhibitors are at treatment and how they can improve survival, but we need to make sure that every woman can take them and maintain quality of life. Because a treatment isn't great if the person doesn't even take it at all. So that is just as important as the efficacy of the drug. This graph actually shows the amount of women that continue to take either tamoxifen or aromatase inhibitors year by year. So most times the treatment course for aromatase inhibitors are 5 years. Tamoxifen could go from 5 to 10 years, but look, after about 4 years, about only 50% of the women that were prescribed to take them are still taking these agents. So clearly this is an important topic. And only recently, when these survey results finally came out in about 2010, did we start to see research dollars going into studies, not just for efficacy anymore, studies to look at treatments for the adverse effects of aromatase inhibitor. Some big news that I got to talk about last year, but I'll update and repeat again this year, is about vitamin D and how that can help not just with bone health, but actually to treat muscle and joint pains. So I'll review that again this year. I did go over it last year because it came out in late 2012. And some increased recognition is due to all of you who are survivors or work with patients who are reporting to you adverse effects, because some studies actually got funded when people were looking at how much blog posting was devoted to talking about aromatase inhibitors, so much that even the blogging got in the news. This is like my favorite 21st century headline. It's about blogging. So it showed how much blog posts were devoted to aromatase inhibitor. This funded a study that was such a well put together and definitive study. This got on the news, the study that was funded after that one. And it was a survey study specifically on aromatase inhibitors, not just on a really vague sexual preference or just vaginal dryness. Usually big studies only look at one aspect. This study was funded to look at 4 very important domains and definitively show what the blog posts had been saying for many years, is that aromatase inhibitors have more sexual side effects than either tamoxifen or taking nothing, as anyone else would do, significantly more as far as complaints about decreased libido, insufficient lubrication, painful intercourse, and women who report they are dissatisfied with their sex lives after taking aromatase inhibitors. So it seems like this should have been information that should have been known years ago, but the funding wasn't there. And then after this study came out, I finally get to talk about 2 funding studies that were looking at treatment specifically for this side effect, sexual side effects, and they were reported just this year. So I'm really looking forward to getting to tell you about that. Yes?
This brings to mind another side effect of breast cancer treatment, which is chemo brain.
Yeah.
Support groups, we were all talking about chemo brain, but none of our MDs would believe it as an entity. And this is similar.
Yeah, and also that, I could make my complaints about sexual health and how slow the funding was, but I think those of you who went to the Chemo Brain conference, they were talking about the ongoing research and not saying, here are the results. I actually get to have results today with treatment, so we are a little bit ahead of Chemo Brain. I hope the research for Chemo Brain will be the next topic I get to talk about, because as a pharmacist, I need to focus on treatments with study results, and right now I don't have anything for Chemo Brain to report, other than I know which studies are ongoing, but not reported yet. So we're a little bit ahead for sexual health, so I'm really happy to talk about that. So just to quickly review why I focus on aromatase inhibitors and sexual health and muscle and joint pains, I need, as a professor, of course, to step back and talk about that drug in the context of all the what we call endocrine or anti-estrogen therapies used for breast cancer. We have selective estrogen receptor modulators, tamoxifen and raloxifene, which means they work by having antagonism on estrogen receptors, but here's the key, they have agonism on some estrogen receptors. So I'll show you which with a picture. Aromatase inhibitors, there's 3 on the market. They all come generic right now and are all options. And there's other ways of decreasing estrogen in the body to prevent or treat breast cancer, which I will not be focusing on today, but have some similar side effect profiles. But really, the good question is, why do I focus on aromatase inhibitors, not tamoxifen as much, although some of the things that adverse effects do cross over, and so you could use some of the same information. And to start with that, let's first think about physiology before we go to pathophysiology, which the adverse effects would be related to. So physiology of estrogen in the body, we have to remember that estrogen does not just help with breast health, and sometimes actually is the cause of breast proliferation or breast lumps and breast cancer, but it actually promotes liver health, bone turnover, bone remodeling, ovarian health, uterine health, is in the adipose or fat tissues, it is in muscles and promotes muscle health, and it does help with cardiac health as well. And this is estrogen that comes from the ovaries. And also, that's not the only place that estrogen is made. Actually, other androgens in the body are converted to estrogen by an enzyme called aromatase, which is in several organs, especially the adipose or fat tissue. But then, if we decrease estrogen all over the body, certain adverse effects could result from this. Now, first of all, the good side effect is a good treatment for breast cancer, because of course we want less estrogen at the breast. However, lipids could increase, there could be bone loss, hot flashes could result, vaginal dryness, weight gain, myalgias are muscle and joint pains, and a controversial study right now, because we don't know the results yet, is whether the increase in lipids will increase the heart attack risk. We don't have the answer to this yet. It does not appear yet that the increase in lipids from these agents will increase the heart attack risk, but we don't have the answer to that yet. And just as someone wisely mentioned before, we're actually still looking at the relationship between decreased estrogen and what's called chemo brain or memory of cognitive problems. So that also could be related to decreased estrogen in the body. And inhibiting with aromatase inhibitors, with the aromatase being inhibited with aromatase inhibitors, that are the adverse effects. Now, just to point out where tamoxifen has a bit of a difference, tamoxifen does not have a decrease in estrogen at all of those organs. Tamoxifen has agonism on the bone and on the uterus. So that results in something that is good because when I talk about tamoxifen, when I do give lectures on that, I don't have to talk about bone loss, bone fracture, bone health. However, I'm not talking about it today, but I do, when I talk about tamoxifen, talk about monitoring early treatment for endometrial cancer, which is a rare adverse effect, but it is a known adverse effect of tamoxifen, but not with aromatase inhibitors. So let's review again where these drugs are acting. Tamoxifen, as you can see at the bottom there, it is an antagonist of the estrogen receptor. And there are estrogen receptors on breast cancer cells. But I just mentioned that there are estrogen receptors on many other organs in the body. And tamoxifen can block the estrogen from the ovaries or anywhere else in the body. Aromatase inhibitors are specific to just inhibiting the aromatase enzyme, and that is one way of reducing estrogen all over the body with no agonism. And most of the aromatase activity increases as the source of estrogen production in postmenopausal women. So that's why aromatase inhibitors are predominantly used and more effective in postmenopausal women, where the treatment of choice is still tamoxifen for premenopausal women. So the reduction again in estrogen can be similar between tamoxifen and aromatase inhibitors in green. There's some things that are similar. They both cause hot flashes. They both can cause vaginal changes and sexual discomfort. But tamoxifen, with its agonism at certain locations, can cause endometrial cancer, cataracts, and thrombosis, where you don't see that with aromatase inhibitors. Whereas with aromatase inhibitors, they can cause bone loss, which can lead to fractures, which is more rare, and myalgias and arthralgias, and small increases in lipids. So that's why I've chosen to talk about some of these today, because the data for aromatase inhibitors, because they're newer than tamoxifen, are just coming out. So that's why I like to update you every year. And also to remind everybody, and also other practitioners as well, is that some of the adverse effects that some people like to focus on because they're very rare and very serious and sometimes get more attention, let's say how we can prevent endometrial cancer from tamoxifen. And I felt like for a while, well, we weren't really looking at muscle and joint pains because people are like, oh, it's pain, aches and pains, there's pain medications out there. We don't need to look at it. But once a survey specifically looked at the severity of the pain that women were reporting and how common it was this type of study which helped us get research funding to start looking at treatments specifically for this type of pain, and that it's not exactly like an arthritis pain or headache pain, and saying we need to know the exact mechanism of this pain and we need some better treatments for it because it's really common. And you'll even see that a lot of women are reporting severe pain. This is not just I ache a little in the morning. This is 8 to 10 level pain. So clearly treatments are needed. And as well, I'll introduce to you again the sexual side effects as a recent study looking at that it is a lot more than with tamoxifen. So we needed aromatase inhibitor specific studies for sexual dysfunction, and we didn't need it to be studied with other things. We need something specific for these medications. Now, just to shortly talk about this topic, which sometimes I get questions on, is this one I hope I get to talk about it more in the future, because right now it's still controversial whether aromatase inhibitors significantly increase cholesterol or not, because it looks like they don't increase cholesterol more than, let's say, placebo or a sugar pill. But it looks like they increase cholesterol more in comparison to tamoxifen. And I wouldn't say a lot more. One was like 9% versus 3% had hypercholesterolemia on the tamoxifen versus an anastrozole study. But what is being looked at here is whether tamoxifen is skewing the results because it's cardioprotective in some way. So we're still trying to look at research whether saying that tamoxifen actually has some adverse effects that are very serious, but again, it has some advantages to it with bone health, and it may actually be cardioprotective. So that what might be the issue why tamoxifen might have better cardiac risk profile than aromatase inhibitors, and not that aromatase inhibitors are really any worse than taking a sugar pill. So this is new data, and I'll continue updating this data in the future. Yes?
Did they control for exercise?
Not in these trials. These were trials for breast cancer, so they recorded exercise but didn't tell people how to exercise on the trials. I'm certain exercise and diet would help alleviate lipid problems if that was done on the trial. You are correct. And a lot of questions regarding some of these adverse effects that we could get, since there are 3 aromatase inhibitors on the market, is which one's the best? Which one has the least side effects? And again, being a pharmacist, I always notice I can never come out and say one is better than the other. There just seems to be pros and cons for each of these agents. And in the end, these agents don't seem to be a lot different when you look at the size of the bars. But what I can tell you here is we have anastrozole and exemestane. And here in the pinkest pink here is cholesterol. And it appears that exemestane raises cholesterol a little bit less. So the amount of people with hypercholesterolemia on the trial looked like 17% versus 15%. So not big differences. So a little bit different on that. But what is interesting, there's always different side effects. Exemestane was the only one that reported in purple here, causing acne. So that was something specific to exemestane. Actually, and also it didn't report on here increased hair growth. So that was something specific to exemestane. And as far as bone health, it looked like exemestane caused less osteoporosis, but only by a few percentage points. So when you're asking what is the best aromatase inhibitor, there could be some slight differences. It's not known whether they're clinically significant. But what you could say is if somebody's having bothersome acne on exemestane, we do know, or hair growth, because it does have a little bit of a steroid component to it, that we did record that anastrozole doesn't cause that adverse effect. So we still have some really useful data coming out of these comparison trials. Even if I don't have one, I can't come and say like, wow, this one looks really, really superior to the other one. So I can't say that, but we did get some useful knowledge anyway. Yes?
When were AIs invented?
Well, they have been out at least 10 years. And
Well, 12, because I've been on them.
yeah, at least, and I don't remember the exact year they came out.
Are they similar in cost?
Now that they're generic, they're all generic, they are. They used to be a lot different when one was brand and one was generic. And as far as the rare adverse effects that we compare but are serious, what we want to look at with aromatase inhibitors, again, just to review the pathophysiology from earlier, is bone fracture with aromatase inhibitors. And tamoxifen is the one that is linked to venous thromboembolism and endometrial cancer. Although that you can see that with tamoxifen, remember, those are not very common adverse effects. And why I do like to talk about bone fracture is that because it's a possibility does not mean that it will definitely happen, because these results were taken before all the new guidelines for bone scans, monitoring, and treatments came out. So I predict if another survey is taken in 5 to 10 years as far as how many bone fractures, if people are following some of the guidelines I'm going to go over quickly, the bone loss could be caught very early and effective treatments could be put into place to regrow the bone. So that adverse effect is not something that is a definite adverse effect. So to review from last year, I did talk about, and I'll talk about again this year, some good treatments for hot flashes, muscle and joint pains, and again, bone health. I did go over that last year. What I'm excited to talk about this year that is totally new are 2 new studies looking at sexual health that I didn't talk about last year because they are very new and came out recently. So just to review, yes?
So you're saying that the vitamin D and the toxin would help with the muscle and joint pain?
So I'm going to go over that study again, even though I did do it last year, just in case anybody missed me last year. I'm sure you didn't mean to miss me last year. I'm not too insulted. I'm just kidding. I do this every year. You can tell your friends, and I'll still be here next year at the same time doing it. So that's fine. I'm going to review everything I did last year right now. So starting with hot flashes, and then I'll go over muscle and joint pains as well. So for hot flashes, we have some studied treatments that have been studied in large randomized trials and have safety data as well and are covered by insurance for these indications. Although I will point out that a lot of new insurances have much more expensive copays for branded products. So Lyrica is the brand of pregabalin, and pregabalin is not a generic yet. So that would be possibly, for some people's insurances, a lot more expensive than venlafaxine, which is a generic product. But all of these products have been compared and actually equally effective to reduce the amount of hot flashes by about 70%. So it doesn't take them away 100%. It will reduce the amount in a day by 70%, not 100%, but it does significantly reduce the amount of hot flashes during a day. Now, no drug has no adverse effects. So it's always a woman's choice to say, do these hot flashes impact my quality of life or daily routine enough to warrant one of these medications? Because venlafaxine is something that can cause dry mouth and during the titration phase can affect sleep. One of the things I don't like about gabapentin, and that's why I'm not recommending it unless somebody really doesn't like the other ones, is it's taken 3 times a day. It's hard to remember that, and it is linked to drowsiness, which most people are struggling with fatigue. And me being 6 months pregnant, I know how that feels, so I wouldn't want something added on to that to make me more fatigued. So pregabalin and venlafaxine are good agents for hot flashes. Yes?
So if you're taking an AI, would these contradict what you're taking?
I'm so glad you asked that, because that was something I went last year. So let's talk about drug interactions. I didn't mention ones with drug interactions that are with tamoxifen or aromatase inhibitors. None of these have drug interactions. Let's say even if you're on tamoxifen and the same treatment could be used. There are effective hot flash treatments that do interact with some drugs, but do work for hot flashes for other people. So there's an paroxetine, has a new brand name, even though you could use it generic, is approved for postmenopausal. I think it's Brisdell is the generic name they're using. So paroxetine, that's an FDA-approved drug for hot flashes. That does have some drug interactions with tamoxifen or aromatase inhibitors. So I'm not saying these are the only ones on the market for hot flashes, but I wanted to give you ones that you wouldn't have to say, well, I wanted this one, but now I just heard it interacts with my medication. So for this population, I'm just showing ones without drug interaction. So you're right, there are other drugs on the market, like paroxetine, for people not on other drugs. Yes?
Does Lyrica also help with peripheral neuropathy?
Lyrica is an agent that has been studied for, the good news is, not just fibromyalgia and diabetic peripheral neuropathy, but a recent study came out for chemotherapy-induced peripheral neuropathy. The issue was it was mostly in an oxaliplatin population. I'm still waiting for the paclitaxel docetaxel population, which I think a lot of people in this room have got, and in this conference have gotten taxanes, which cause peripheral neuropathy. So that study is actually going on right now, and I expect those results next year. So we do have some results and for pregabalin. So you are absolutely correct. Yes. Yes, I can. Black cohosh, and then I can that's kind of good because I can skip that later. So herbal products, we mentioned that right now is a good time to say, and I think everybody in here knows it, but we do have students in the room, we don't want to give hormone replacement therapy, sometimes called HRT, like an estrogen containing, it used to be called Premarin or other products, to women that have breast cancer to treat their hot flashes because the estrogen is what we're blocking with this agent, so we don't give more estrogen. There are some herbal products that actually can be converted in the body to estrogen-like components called isoflavones. They're actually not the same compound is an endogenous estrogen, but they have some metabolites that end up in the liver turning into something that looks just like estrogen. The one that's definite is high doses of soy, but it's actually higher doses, not dietary. Some of the supplements have some estrogen in them, the capsules. And red clover is a compound that has high estrogen activity. Black cohosh is really controversial, whether that actually turns into an active estrogen or not. I've seen studies that look at the estrogen that completely contradict each other. So right now, I'm not going to say that I think that it's safe, go take it for hot flashes, or that it's unsafe, because I've seen two completely conflicting studies on that one. So I'm going to just wait for more data. What I can say was it was compared to these agents by Dr. Loprinzi, who is a researcher who's fantastic, who actually visited us at the Vermont Cancer Center, does a lot of hot flash research, and he has tested black cohosh and found it to be less effective than these agents. However, I know that there's interest in natural products, and I understand that even with these agents, they have costs, they have adverse effects, that everybody still wants to know about natural herbal products. So I don't have safety data right now to say it's safe, and I do know it's less effective than these products, but I'd like to see more research on it, certainly. So any other questions on black cohosh? Yes?
No, not on that.
Yeah.
Just you mentioned soy. So what is the relationship? Because I know there's a big controversy over using soy for, to fight breast cancer or not.
You'll see from the dietitians also when you go to their talks, they are not limiting dietary sources of soy, but there are high dose supplements and capsules. And that's what we're telling people to avoid, because they have some other things thrown in which are very estrogenic in them. Yes. Yes.
Well, what about good old edamame?
That's a dietary source. Yes, dietary sources. Yeah, and our nutritionists at the Vermont Cancer Center are great about, saying what normal dietary intake is, because some people could really want to eat like a whole lot of it and take out other forms of fiber and other things with their diet, hearing that something is really good. But our dietitians are great about saying what like good portion size would be of tofu or soy on a daily basis. So actually, I think Jennifer May is speaking next, so we can ask her. So that's a good question. So I do sometimes have bad news data, but it's always nice to know, let's just focus on the good thing, is people are researching these topics. That's great. People are actually putting research dollars into adverse effects, but sometimes the results are negative. So magnesium was researched and looked at to treat hot flashes, and also there was a secondary objective to look at muscle and joint pains and cramps. Didn't work at all. Completely negative study for every outcome, and it was presented this summer at a conference we went to in Chicago called the American Society of Clinical Oncology. So unfortunately, that does not look like an option to treat hot flashes, cramps, or muscles and joint pain. However, let's talk about vitamin D, because I know you're interested in this. Vitamin D was positive, was presented in 2012. Acupuncture was positive and presented in 2010, although I'm not an acupuncture specialist, and I know there's better speakers on that at this conference today. So I'm going to just talk about vitamin D. So this study was presented in 2012 at the American Society of Clinical Oncology, and was high-dose vitamin D. So keep that thought for a second. It's 30,000 units. That's not a pill size that you can buy just from your local CVS or Rite Aid. This was a prescription strength of vitamin D. Vitamin D was given weekly for 12 weeks, and then a pain scale was done after the trial, and showed that, again, this wasn't perfect. It didn't reduce pain in everybody by 100%, but this was a measure of the severe pain in the severe category, the ones that were reporting 8 to 10 pain, and women who in 61% had the pain went down to 38%. Were still reporting the pain after the trial. So a number of people said, and there was no other pain control given in the trial. A number of patients said, I took the vitamin D and this worked for me for the pain. So this is a possibility, but no, it does not work in everybody. But it could be a trial. The caveat is with vitamin D monitoring, not with somebody adding up a lot of small vitamin D supplements from the pharmacy and taking this high of a dose on their own. There are actually side effects of too much vitamin D, but only at very high levels. The level's about greater than 150 blood level. and 50 is a normal blood level, or 30 to 50. So it's a pretty high level, but at that level, that can result in kidney stones, which I would think are very uncomfortable. So there is an actual side effect, yes.
Is this from the previous slides? It was 30,000 international units a day?
For 1 day, once a week. You take it 1 day, once a week. 1 time, once a week.
Okay.
1 time
How
during the
does
day.
that relate to, we've heard, the doctor who wrote a book about vitamin D, about, I don't know, when it was really big in the news and in magazines, said
Yeah.
don't take over 10,000 IUs daily or week. I've forgotten that. But Marie Wood today, in her presentation on bone metastases, said don't take over 4,000 IUs.
Absolutely. That's exactly what I'm agreeing with. People can buy 2,000 to 4,000 units at the pharmacy and should not do this on their own. The maximum is recommended 2,000 a day, and there are pills. There are studies saying that up to 4,000 a day, if people take them, will not result. This is safe when a doctor is monitoring it with blood levels, because everyone in this trial was kept at a level of less than 150. So nobody should do this on their own. This is a prescription strength. Yeah, yeah. This is not something.
One, sorry to share this, but I was at 23 and I did 9 to 10,000 IUs. Is it a day? Yeah, a
Yeah.
day, daily. And in a month, my numbers were at 53 where they needed to be.
Right.
Just a study of one, an anecdotal.
And exactly, you got your level checked, so you knew when you got to a level, and then you could probably save yourself some time and not take such high levels. But I've heard of people saying, well, I heard about this study, and going out and on their own, never telling any doctor, taking tons and tons of pills, never having their levels checked. So you're doing exactly what we'd recommend. You got your level checked, and you got to a perfect level, and then you could take less and save some money, less vitamin D that way. Yeah. Exactly, especially for people like you, pale like me, that wear sunscreen like all the time and can't not wear sunscreen. So definitely I try to eat my vitamin D and have it checked, but I would not overtake it. So not something I would do. So we have some new data. Like I look forward to, even on my 5th year, it'll be my 5th year talking about it next year. I have something I know I'm already going to be talking about next year. The duloxetine study will be coming out by next year, and it is being studied for muscle and joint pain. The omega fatty acid will be published. You haven't heard of this yet. I heard through the grapevine it was completely negative, but you'll get the results that it was negative in the next year. And we have a new study that unfortunately won't be next year. I predict the zoledronic acid study will be ready in about 3 years, that we can look at to see can that drug be used to treat muscle and joint pains from aromatase inhibitors. So we have some good news to look forward to at my future presentation.
I don't recommend the last one because that's a bisphosphonate.
Right, let's talk about that now.
Okay.
Let's talk about it. We have to monitor for these drugs. Every drug has adverse effects, like you're mentioning, and we can use them safely, and some people can't get them. Some people have to have them stopped. But first, let's make sure we need to be on them. So that one would be useful as an agent when people have some osteopenia. I like when drugs can actually do 2 things for us. It would be so nice that zoledronic acid can not only help with bone health, which it does, but it could actually help with muscle and joint pain, but I don't know the answer to that yet. But for now, we do need to look at to see, we don't guess that just everybody with aromatase inhibitors has bone loss. We need to check, but it is important that women do get a bone scan if you're on an aromatase inhibitor, and the recommendation is to get a baseline at the first year of taking an aromatase inhibitor and then get it followed up every 2 years to see if osteopenia ever develops, because the progression to osteoporosis can be stopped in its tracks by very effective agents. And yes, you have the right idea that they are not devoid of adverse effects. So they're not the perfect drugs. I wish there was one. But what I do know is that they stop the progression of osteopenia to osteoporosis and do prevent fractures from agents that cause bone loss. Not just, they are approved for aromatase inhibitors, but also for those people on high-dose steroids for rheumatoid arthritis and other conditions, they might get osteoporosis, drug-induced osteoporosis as well, and these are both effective treatments. And the good thing about having options here is that if somebody is concerned about adverse effects or gets some of the adverse effects that's listed, that we have 2 equivalent drugs that can be used for osteopenia. One is not better than the other. They just have preferences for individuals. Like one is subcutaneous, and one needs an intravenous injection, and one is yearly, and one is every 6 months, and they have completely different adverse effect and monitoring, which may be preferable to different patients once they get those, but neither drug is devoid of adverse effects. So those are agents that can be used for osteoporosis. So before I move on, and I did go over that last year, but I'll take questions on those before I talk about the 2 agents that I'm going to talk about for sexual health. Yes?
I can't help myself. Zometa, zoledronic acid.
Right, yes.
Is that the for osteopenia, you said?
Yes.
That's the recommended treatment?
There's 2 treatments that are, they can be used for osteopenia or osteoporosis, but these both are approved for both osteopenia and osteoporosis. The once-a-year dose is for osteopenia, and the twice-a-year is for osteoporosis.
Okay.
Our goal is to not get to an osteoporosis, so osteopenia.
When we have bone mets, as I do,
That's a totally different dose.
that's a different story.
That's a different dose, yeah, and a different frequency and a different dose, yeah.
Okay, how comparable is Fosamax to
That is a good question. That's
Zometa?
in.
Do you know that?
For this indication, let's go over indication by indication. It is absolutely less effective for bone metastasis. That study is very clear for bone metastasis. Still controversial for osteopenia. The results are very close between these agents and the oral bisphosphonates that include Fosamax. So it's very controversial. The American Society of Clinical Oncology recommended these even though the study was close. And do you know why? It wasn't on efficacy. It's because the adherence rates were so low with the oral bisphosphonates because they cause gastrointestinal upset, heartburn. The people weren't taking them, so they were fearful that people were at risk for fracture if they chose one that people wouldn't take. So the American Society of Clinical Oncology is recommending these that don't cause heartburn or gastrointestinal upset. That makes sense? Yes?
What's the side effect with dental exams with these?
Dental exams can help prevent. That's a very good question. Ever getting a very rare side effect called ONJ, or osteonecrosis of the jaw. Osteonecrosis of the jaw has been linked only with people that have very serious dental conditions that weren't treated, and then they started this agent because these agents don't allow the bone in the mouth to heal ever, so it just stays, it gets worse and worse. But when all that dental correction is done prior to starting these agents, that effect hasn't been seen. So again, that's a preventable condition, ONJ, but we do care about it. Even though it was really rare, we never want it to happen. So getting dental work done prior to treatment. We've even delayed therapy based on that. We gotta wait till we don't start the drug. Like we get the dental work done first. So good question. Let's finish with some new studies for sexual health. And last year, I talked about lubricants and vaginal moisturizers, which actually are studied. I know those don't seem like they're over-the-counter products. They don't have an active drug in them, but a moisturizer, just like a moisturizer for our skin, when we have itchy skin, is a treatment. And we do have studied lubricants and vaginal moisturizers that are recommended for sexual health. But this year, we have some updated results on vaginal estrogens and an updated study on vaginal application of DHEA. So first of all, this is a topic I wished there was some more data for in the years past because I'd heard this from a lot of people, but you know, some researchers are like, well, there's other things, there's moods involved and self-appearance that's involved in the sexual dysfunction, and finally pathologists just took samples of the vagina and actually showed that aromatase inhibitors cause it to shrink and have less cells that produce moisture, and they documented it. And so now we can really specifically target some treatments. And this also makes sense because there are estrogen receptors all over the genitourinary tract. So we do need to specifically look at this area. But the guidelines for this particular issue of sexual health and can we use topical estrogens is clear as mud. So you look at any website, okay, I want to know, they say it's safe. The North American Menopause Society says for women with hormone-dependent cancers like breast cancers, moisturizers and lubricants are recommended first line. Clinical trials do have concerns about oral hormone replacement therapy and suggest harm. On the other hand, data are lacking for safety of low-dose vaginal therapy. Recognizing that systemic absorption of estrogen from low dose may be minimal, it is not known whether even a small amount of absorption will have any negative outcomes. So each woman should talk about their preference in consultation with their oncologist. So they're so vague, they don't give a recommendation for or against. But we actually starting to actually have some data that we can either feel safe about or not feel safe with certain products. So these certain low-dose topical estrogens and hormones that are being looked at in studies are vaginal rings and tablets, vaginal creams. We don't have a study yet on Ophina that's out, but it's being looked at, vaginal testosterone and vaginal DHEA. But the question is, do they increase estrogen levels? The theory was to look at these androgens in the local, just the local vaginal area, was the hope that testosterone wouldn't be absorbed and converted to estrogen. That has completely been disproven, so we are not recommending testosterone. DHEA is being looked at because it's an adrenal androgen to possibly not be converted into estrogen. And estring and vagifem are low-dose estrogens that we're looking at to see if they get absorbed to the rest of the body and could get possibly to the breast. So I do have some results on vagifem. Unfortunately, that was a negative study and not good news, and it did raise the estrogen levels that were in the blood levels all over the body. So it did appear that the vaginal administration of vagifem was absorbed from the vagina and in significant amounts, because that's why the line went up a lot, because the estrogen levels went up a lot after, and that's the blood level, not the vaginal level, after the vagifem was taken. Then, so we were done with testosterone, looking at testosterone, we're done with vagifem, so we started looking at DHEA, looking at this promising agent. It's an adrenal androgen, and for women on aromatase inhibitors, it looks like right here that if the aromatase enzyme is being inhibited, which aromatase inhibitors do, that the conversion from DHEA, which is dehydroandiesterone, wouldn't be converted to an active estrogen or androgen when you're blocking the aromatase inhibitor. Now that's the theory, that's the hope. So now we finally have a study that we're going to look at to see if that theory is correct. Also, there was additional good news in animals and in cell and laboratories that they actually found that possibly because of this mechanism, giving DHEA was actually a cancer treatment. It wasn't actually causing cancer, it was the opposite, that it looked to be actually halting cancer, but this is just in animals and in cells. So we're not looking at it as a treatment in humans right now for cancer, but this is actually just really promising news for this agent and shows why it was studied. So first we looked at what dose wouldn't be absorbed into the body at all for DHEA, and so I know I'm running out of time, so I'm going to go over to the actual study quickly, just to show that the dose that's used in the study I'm about to go over, which is 3.25 to 6, shows it did not have high levels absorbed all over the body. So first we measured that first in the first study, and let me get to the study results here. So this study for DHEA was a large study, 224 patients in 82 different centers, and they were randomized to DHEA or just a plain placebo vaginal moisturizer. And unfortunately, one endpoint at 12 weeks was not statistically different, which was the dryness endpoint, but there were improvements in secondary endpoints in the sexual function survey, quality of life survey with this agent. So again, this is not the perfect agent that it helped everybody with every endpoint measured in the study, but it did have some improvements. And here's what the good news that everybody was looking at, because we have to look at the blood levels and whether this agent turns into estrogen in the body or testosterone, and it didn't. And not only that, we can measure what estrogen does in the body. They even checked bone turnover scores, they checked lipid markers in the study. So they're really showing that this is safe. They really covered their bases here. So this was a high quality, large, controlled study that did show it was safe. Now we could argue that it did not have the efficacy that we were looking for, but it had some promising results. So we could say that it is possibly an option that could be tried. So let's talk about vaginal DHEA versus estering. The estering study I went over last year. And let's point out the cons of that first, because we can't due to time go over the whole study. But the con was, one, the estering study was much, much smaller. It didn't have 411 patients, it had 36 patients. So the quality of the data is not as strong for estering. Also, it did show some estrogen-like activity, not very, very small increases in lipid and bone markers, but it did have some increase in activity, but it was considered very small and considered still an option. And it is available in pharmacies and covered by insurance. And it has less messy administration than vaginal application of a topical vaginal product, and it's inserted every 3 months. So those are the pros of estering. Vaginal DHEA that was used in the study by Dr. Barton, it is only available at compounding and by mail order, unfortunately. It is a compounded vaginal application. And the good thing is it also serves as a vaginal moisturizer. And it was, I have to say, it looks the safest product that has been studied, except for, of course, Replen's and vaginal moisturizers that looks to be available. It is, unfortunately, also a daily vaginal administration, so that means more mess and less convenience. And just, of course, the caveat to all of this is that we need to see a lot more long-term studies before these can be first line. First line is still going to be vaginal moisturizers, and this will be second line. So let's give you the useful details before people need to leave, if you're interested in this. DHEA, when this study came out, I am a pharmacy professor, and we do have links to every pharmacy in the area, and we have our students go there, and we make relationships with all the pharmacists. So, of course, as soon as I got back from this meeting, I went right to Penrose to our co-professors over at Penrose who helped teach our students compounding and made sure that they had the recipe, that they know how to make this, they're ready to make this whenever anybody wants it. They are ready. So the cost is $60, and unfortunately, as with many compounded products, it's not insurance covered unless you beg your insurance company on your own, and that's the key with many products that are compounded. The way it's used is Penrose will give a vaginal applicator, and it's used at night. Yes?
Is there any role for pulse dosing rather than daily dosing?
I'm glad you just asked that, because this is what's being done in the extension arm of the study. The study went on for 12 weeks, and then it closed. But then they told the women who liked it, they actually tried testing less usage to save some money. And they've reported to me personally, because Dr. Loprinzi was on site here, that it was effective to only go down, after 12 weeks, to go down to every other day, or even twice a week, after the 12-week study, to lessen the amount of administrations, and women still reported it to be effective. So that is an option. And then, just like you said, on the days without the DHEA, continue to use a plain vaginal moisturizer. The other issue with this study is it was not published yet, so you may need your doctor to contact me to give them the results. And here is, if you also need the doctor to ask me, we have a practice prescription that we practice with our students at Penrose Pharmacy. But also there is a mail order pharmacy that is listed here that also has agreed to send it to anyone in the United States. And it is a little bit less expensive, but it is mail order. You have to pay for shipping, and it is called Gateway Pharmacy North in Bismarck, North Dakota. Of course, you do need a prescription for this, so if there's a physician who needs help with this, that's why I keep an example on hand so I can help people write prescriptions. So let's summarize this topic, and then you can ask me questions. So you used to see an algorithm last year. When you left this talk last year, it talked about the first two bars on this graph that we recommended vaginal moisturizers first, like Replen's, as a first-line option for vaginal dryness and atrophy, and then lubricants prior to sexual activity. And the ones that should be chosen, preferred by most people, are natural, organic products without scents, flavorings, and there's a lot that to choose from. Here's just a couple options that I found in local pharmacies, like Astroglide Free, Please. I think there's one called Wet. There's one called Sliquid, and there's Wet Natural in pink. There's a lot of options, but the key is KY has a lot of chemicals, so that's not the one I'm recommending. And then the update to this year is that we can actually start discussing vaginal DHEA and estering because we have more mature results. We can talk about not that they're 100% effective, nor do we have long-term outcomes. What we're talking about is the risks and benefits, pros and cons, and discussing them to allow our patients to choose if they want to try this based on not having the other options working as effectively as they would like. So your pharmacist, like me, can help you choose and go find in the pharmacy where these products are. And I do teach a class at the pharmacy school to teach my students to help people find, because these they're just mixed in with everything on a huge wall in the pharmacy, and they don't even separate out the moisturizers from the lubricants. They're all on one wall. So I'm trying to help my students by showing them pictures, say, hey, take down Replens and separate some lubricants and choose one of each, because you do need one lubricant and one moisturizer, and there are options. So you can ask my students, they are trained to do this, or you can ask me starting right now. Go ahead. Yes.
I take tamoxifen, and the side effect that I got, besides the weight gain, was hot flashes were unbelievable, and like 4 at night, and I couldn't even sleep, and I would be soaking wet, and I'd already gone through, the change of life. But my doctor didn't recommend one of the 3 you had on the wall. I'm taking an off-market drug, and the drug has made all the difference in my life.
Would you be willing to share, to
Sure.
give us an option?
Say a couple, so I can't remember.
How about paroxetine, or Prozac is fluoxetine, something like that?
It's actually used for an antidepressant.
Yeah, so those
What's the
Paxil and
stuff?
Prozac.
No, it's something, what it's used for, it's not one of those, but it's used as an antidepressant. They don't know why, but it helps for hot flashes. And then I was really leery, so I spoke to the doctor, then I spoke to a pharmacist, and then I have a friend who's a pharmacist, and she wasn't familiar, went back and did the research and said, this is unbelievable. I'm going to start using it, recommending it.
Yeah.
And it has made all the
Well,
difference in my life.
venlafaxine is an antidepressant. It used to be called Effexor, so you could share with me later what
Yeah,
it is,
okay.
because it is an
I need to
antidepressant.
put it on my phone. So
Yeah,
but
yeah, because it might be that, because venlafaxine is
stop
called an
taking
antidepressant,
tamoxifen
but
because it was
antidepressants have a lot of other uses. So venlafaxine, which is on the slide, is considered an antidepressant as well, but it's also good for hot flashes. So
I see.
yeah, so it could be similar since you said yours was an antidepressant. Yes. Anybody else? All right. Well, you can come up and ask me a question as you're walking out. Thank you.